SparksCast Unleashed. Real stories, real health innovators. Today, our host Reese Gomez speaks with Justin Kromelow. He's the world's leading expert on opioid management and regulatory compliance. His company is the only winner of the Life Sciences Review Top Regulatory Services Award. He's a published author and multi-award winner of the National Science Foundation.
Welcome to the show, CEO of OPOS, Justin Kromelow. Justin, how are you doing today?
Good, Reese. Thanks for having me here, and thanks for the opportunity to share a little bit about what we do at OPOS.
It's our pleasure. Justin, you and I have had a number of conversations about kind of opioids in general and what the perception is in the public eye about it and misconceptions as well. And I thought we could kind of start there a little bit about what you've seen out in the market and how it's affected the whole opioid industry and the way physicians and patients think about it.
Yep, that's a great question, Reese. And I think we have to start the story about 5,000 years ago. And I won't chronicle you to kind of decade by decade, but the reason that I say we have to start 5,000 years ago is because it was recognized 5,000 years ago by humans that opioids had a natural power to manage pain. And opos is actually the ancient Greek word for the milk of the poppy. And when we talk about the opioid epidemic, when we talk about the context of limited access to care for chronic pain patients today, I think we have to ask ourselves the question of how is it that we've had opioids for 5,000 years, but we seem to be the only kind of generation that can't seem to manage them properly. And so this is a relatively recent phenomenon compared to this extremely long history. And so there's a lot of different reasons for this, but I think what we really want to focus on is how can we really improve and increase access to care for the roughly 20 to 25 million Americans that will utilize long-term opioid therapy for basic independence and quality of life. And I think where we have to think about is that our response to the opioid epidemic was essentially to shut down opioid prescribing, to make it so difficult, to create so much fear with both providers and patients that we reduced the number of prescribers in half. And kind of going back, there's been a lot of guidelines developed over the last decade, but we knew from the CDC data in 2014 that there was an inverse relationship between prescribing and opioid overdose deaths. And so what that told us was that the overdose deaths weren't coming from prescribed opioids. If we look at it from a population perspective, when we talk about things like opioid use disorder, we're talking roughly maybe 2 to 3 million people. But when we talk about the number of people that benefit from long-term opioid therapy, we're talking probably on the low end about 9 million people. And cycling on and off long-term opioid therapy, maybe close to 17 to 20 million patients.
Wow.
So, we've made incredible headway in fighting the opioid epidemic, but we've done that at the cost of really disregarding and neglecting care for a much, much larger percentage of population, roughly 20%, a little over 20% of US adults. So it's really not a very good trade-off that we've made.
That background, fascinates me because, think about it. If you would think that in more modern times, we would have better ability to be able to manage this than it was done years ago. But like you said, it started to turn into an epidemic under the modern times. And what was interesting to me when what you've talked about, Justin, in the past is how opioids for some patients is really the only thing that works to control their pain. And now with this access to care issue, a lot of people who really need it don't have access. Can you talk a little bit about kind of that clinical side of it and why really their only alternative is opioids and what the challenges have been in getting access to the care that they need?
And so that's a really good question, Reese. And I think it lets us look at some really interesting perspectives. Most of us live pretty healthy lives, and we can kind of wake up in the morning and do whatever we want. And when we're not feeling well, we go to the doctor. We expect that we have a surgery or something, and we get fixed and we're feeling great again. But what happens with many people is they'll have a surgery, they'll have something, and they have imperfect healing. They have nerve damage. They have other things that happen. And keep in mind, too, that, we think of things like MRIs as being kind of the gold standard for things like diagnostics. But think about this. When you get an MRI, you're lying down and you're not moving. Is that how we spend our lives?
No.
No. Right? From a functional perspective, and the things that you have to do, whether you take care of children, whether you take care of a family, whether you go to work every day, whatever it is that you do, it's a dynamic activity and an ever-changing environment. And so chronic pain can come from a lot of things, but at the end of the day, most of the patients on long-term opioid therapy have tried everything available to them. And so opioids themselves are not a first-line treatment. So you're going to, really try all of the simple stuff first. And a lot of folks, there's nothing to operate on. There's nothing that we can point to and say, if we cut this out, if we repair this thing, you'll somehow get better. And in many cases, the surgery, the procedure can be worse than just trying to manage the chronic pain. I think it's interesting to note just the large number of patients that we're talking about. And when we look at it in the context of U.S. healthcare, I think one of the inconvenient truths, and this is something that we're having to come to terms with today, is that opioids, when they're managed appropriately, are the lowest cost treatment option. And so for so many patients, we've taken that off the table. The fact that we reduced the prescribers by 50% means that you're not going to just go see a doctor and have a doctor prescribe opioids after everything, after you've tried everything and it's failed. When we look at one of the sources of overdose deaths, it's to a certain degree, folks that have been pushed out of the healthcare system because either their prescribers retired, their prescribers no longer willing to write opioids. And, from our customers and the people that I talk to every day, their practices get calls every day from patients looking for somebody to take over their opioid prescription. And they simply don't have the capacity.
So basically, if I am understanding it right, there's a bit of a dilemma. So part of the reason there's been an epidemic and a crisis is that the providers have sort of started to back away from prescribing. And so because of that, the people who really need it, they don't have the access to the care and the control. So they figure out other ways to get it, and they do it in a way that's not in the best interest of their health. Is that the right way to think about it, or is it a little different?
Really high profile people who are examples of that. Tom Petty is one. He suffered from chronic hip pain, and he was on tour, and there were stories about he could barely walk. They had a golf cart to move him around to get him on stage. He sent one of his people out to get some pain medication because his pain it may have been managed well when he wasn't on tour, but with the demands of being on tour, it wasn't managed well enough. Another one is Prince. Prince died of an overdose for the same thing. During a tour, he was on a flight back in incredible pain. Somebody had gotten him some medication off the street and he overdosed. And so it's not an uncommon story. I think that's the last thing we want to do is push people out of the healthcare system. We have to also look at how complex the healthcare system is. So in the 2024 American Medical Association opioid overdose report, so they do a report, AMA does one every year, they specifically identified insurance companies and the big box pharmacies as contributors to the lack of access to care. And what they talk about is that both the carriers, big box pharmacies have all of these just outdated policies about maximum number of pills or specific dosage ceilings, things called step therapies where you have to try certain amounts or different things before you can do something. And when we talk about the doctors not prescribing and those numbers cut in half, it's because when you combine those hassles with all of the regulatory requirements for every single prescription, and historically hydrocodone, which was the top opioid analgesic prescribed in America and one of the highest prescribed medications in America, switched from the DEA schedule of Schedule 3, which is a medication that you could get 5 refills, to Schedule 2 with no refills, basically from a standard of care perspective, requiring an office visit every month.
Oh,
and so think about, a model where you could see a patient twice a year, and now you have to see them 12 times a year. So actually doubling the amount of visits you're actually times 6 the number of visits that a patient has to have. And I'm not advocating that patients should be seen less, but it has to be dealt with on an appropriateness level. And there are some patients that, using telemedicine, using other tools, don't need the frequency of visits. There are other ways to know a patient is doing well than giving them 6 or 8 minutes with the provider versus, high risk patients that are in more of a dynamic state where maybe they would be better off being seen every week. But our healthcare system doesn't differentiate those things. We see a patient for 8 to 10 minutes once a month, whether they need it or not, and whether they need more time or not, they typically aren't going to get that. And that's not specific to chronic pain or opioids. That's how our healthcare system works.
So basically, you sort of have this double whammy of patients to get proper care need more time with the doctor, or at least an appropriate level for their condition, and now you have less providers. So now you have this contention. Now, one of the things that you mentioned is the cost piece. That what are the alternatives that from a pain perspective, and how do opioids kind of rank against that? Because it sounded like they are the most effective and the lowest cost, which is rare. So I think about alternatives and where opioids fits in that spectrum.
So, the way that we like to think about it, we think about what's called multimodal approaches or multimodal treatment plans. And that means think of opioids as having a role, right? But it's not the only tool that would typically be used with a patient. And so what you want to do is have a number of different things. And the idea, and this kind of the more modern aspects of pain management, we really don't care. They'll ask you in an emergency room on a scale of 1 to 10, what's your pain level? And for acute pain, that can be helpful just to understand pain relief. But for chronic pain patients, in one real sense, it doesn't matter, right? Because you can only reduce the pain to a certain level. And you don't actually care what the number is, but what you care about is what can that patient accomplish? What are their functional goals? And this gets back to what are they able to do? Are they able to do the things that give them a rich and fulfilling life? Or are they limited by pain? And so what we want to talk about are things like using the opioid to enable them to do other things, like develop the core strength to have a walking program. So they want to walk their kids to school. They want to be able to walk to the grocery store, to walk to the community center. Really sort of basic things. Live independently, be able to load the dishwasher and empty the dishwasher, do a load of laundry. And so these are things that all of us take for granted in our everyday lives. But when you think about people who struggle with those things, it can be the difference between living independently or having a job and being able to provide for your family and not being able to do those things. And so each patient's a little bit different. But I think that when you look at kind of the last decade, the last 10 to 15 years, and we've taken that off the table for so many patients, I think that's one of the things. And there's some other people out there who have articulated the same opinion that I'm going to share with you. And that's why we've seen the growth in the chronic pain population in the US move from 20 million patients to 25 million patients. And I think there's a sense that by not having opioids available, we essentially have grown that number of people with chronic pain because they just don't have the relief. It's not available to them. And, it's a little bit of a vicious circle from that perspective because we never get out of it. And so, there are a lot of different techniques, cognitive behavioral therapy, all different kinds of coping skills. There's interventional pain management that can also be very helpful when used in combination with some of these other therapies. There's physical therapy. There's acupuncture, there's massage therapies, there's so many different things, which then gets us to another topic, which is that in order to pursue all of the potential possibilities, that's something that only the patient can do, but they need education. They need to know what resources are available in the community. They need to be able to discuss these options with their prescriber from an informed perspective. But I can tell you in an 8-minute appointment, there's no way they're going to get into any of that. And so one of the things that we really do a poor job in pain management is really being able to discuss with the patient what all their options are and letting them kind of decide what would be best for them. That's why in our program, patient education is a required component. Not only does it meet regulatory requirements from state opioid prescribing guidelines and the CDC recommendations, but it really is the basis of empowering patients to make better decisions about their care, to make more informed decisions about their care, and not live in a vacuum where all they really perceive is access to medication. And, as I started this whole long explanation, we don't actually care what the pain number is. And if you start trying to chase the pain number with medication, you'll end up with a medicated patient who can't get off the couch. They're in no pain, but they can't accomplish anything.
Yeah, so it's a balance. It's a balance that you'll find. I got you.
And the patient will find it. They'll tell you how the balance is affecting their quality of life. Are they interacting with their family, with their friends, with their community, with their coworkers? And that's really what we want.
What was interesting, what you mentioned was about costs. Can you give me a sense in terms of if I'm managing a population, say in an ACO, or I'm managing a population in a health plan, what is that cost differential? Yep. How would I think about that if I were managing a population of patients and sort of looking at the benefit of the cost of this?
So chronic pain is the highest cost chronic disease. So you may think of some other diseases, it's more expensive than cancer. It continuously consumes resources. And so, there have been a number of different studies, but there's kind of an average figure about $35,000 a year on average. And it can go higher than that and it can go lower on that. But the reason it gets so expensive is a lot of procedures, which really only have kind of short-term benefits. And a short-term benefit can be okay if it enables you to do something. But you can't string together a lot of short-term benefits and create a long-term. The other expenses are related to emergency room visits. If a patient's really having issues, that's where they're going to end up in the ER because they really don't have any other access to care. So that becomes very expensive. And so if we can use opioids to stabilize a patient, and again, opioids aren't appropriate for some patients, but for many patients they are. And that speaks to the numbers that we've been talking about. So if you can stabilize a patient, and, when I say stabilize them, we have to recognize that the concepts of risk are dynamic. So you could be stable and you're fine today. But I'll give you a great example because we're in spring now. So you're an avid gardener. So it's the first day of spring and you suffer from low back pain. And so you go spend all weekend working in the garden. So what happens Monday morning, you can't move a muscle. You can't get out of bed. You're in excruciating pain, right? So all that was avoidable, right? There's a technique called pacing where, if you understood it and somebody had reminded you that, hey, Reese, you've been inside all winter long. So try maybe gardening for an hour or two. And maybe get somebody to help you with the real heavy things and then see how you feel, right? We could probably avoid potentially an ER visit or certainly lost days from work. Maybe, you couldn't take care of your kids those days because you couldn't get out of bed. So there's a whole cyclical nature that has to be managed. And that's about the education. That's about monitoring the patients. That's about being able to have insights around things like depression and anxiety and how those may affect the chronic pain and how those may affect their ability to be productive. And like I say, pursue a high quality of life, independent style of living.
I know you've had a lot of success with your solution out in the marketplace. And I was just kind of curious if you think about what you just described as the challenges. Can you sort of tell us how your solution addresses those challenges that you mentioned and how it all comes together into kind of a comprehensive program?
So let's start with two really basic principles. Let's ensure that every opioid prescription that a provider is going to write is going to stand up to medical board, DEA, or other regulatory scrutiny. So let's make sure that they've been thorough, they've done everything that the standard of care dictates that they do. And let's make sure that that's in every single note. So if there's ever any question, whether there's questions from the insurance company or the pharmacy or the regulators, everything is in that note. So ensure that the risk is managed. And while we're managing the risk, let's try to work with the patients and the provider to answer one question. And that question is, what's the smallest amount of opioid that leads to the highest level of patient function? And that's a very interesting question because unlike other medication with opioids, the more you take over time, the less they work. You develop tolerance. And as you increase the dosage in order to help manage the pain, the patient is developing tolerance. You're also increasing the mortality and morbidity risks. So you're increasing the risk to the patient. And even from a professional perspective, as a prescriber, you're increasing your own risk. And so you hit these ceilings where more medication actually doesn't help. It makes things worse because you get side effects. And then you get, potentially sedative qualities. So the patients are tired and then they're not sleeping well, or they're tired, falling asleep during the day. And so it really is a dynamic situation. And the patient has to understand, in order to answer that question, they have to understand what all the different facets are. So the first thing that we introduce is patient education. So every patient that's on our platform will attend an education session once per month. And they attend those sessions throughout their time on long-term opioid therapy. And they're group-based sessions. And one of the things that we like to point to in chronic pain, and especially opioids, is that it's kind of a finite world. There's a certain set of experiences that every patient shares. And if you haven't had the experience yet, it's not a question of if you will, it's a question when you will. So there's a huge benefit from patients being able to interact with one another. And we do things to protect privacy for HIPAA. So the patients can't see each other. The providers can see all the patients, but the patients can hear each other. So they can engage in discussions. Their identities are hidden from one another. So the providers know who the patients are, but the patients have a level of anonymity amongst each other. So that's the first thing. The second thing is, let's monitor the patients. And based on what the patient's functional goals are, based on what the risk level is of the patient relative to other medications, or how stable they are from a pain management perspective, let's use different tools, different psychometrics to measure things. And let's use those measurements as an objective yardstick to support a conversation between the provider and the patient. And to make things a little bit easier on the provider, let's create risk-based cohorts of patients. So the provider can do things in a standardized way and know that for these different risk levels, this is what I'm going to do, but I'm doing it in a consistent way so I can be thorough and I can deliver high quality care consistently. And then let's give the patients the opportunity to receive their prescriptions or to do medication monitoring in groups as well. And so it can be very convenient. It has the educational aspect of hearing about different patient experiences. And what it does for the provider is it frees up a lot of their time. So instead of seeing, 20 patients in a day, they could see a group of 20 patients in about an hour or an hour and a half. And what ends up happening when you move out of that 8-minute revolving door model is you free up an incredible amount of time that now the providers have time to spend with the high-risk patients or the patients that have a need. And what our customers tell us is no longer are they scheduling patients 3 to 5 weeks out. They're able to usually get a patient in within a couple of days.
Wow.
Sometimes even the same day. So, when we think about a group model, what it does is it actually ends up delivering much more personalized care. And one of the interesting things that we find is because the patients interact with a mobile device for the data collection, oftentimes they're much more honest and direct. They don't feel like they're being judged. And that's really helpful to providers in order to fine-tune treatment plans and recognize things like depression. We have some questions that get into self-harm, contemplation of suicide, things like that. And we'll let the providers know right away. And I think oftentimes those are a lot of issues that would go unrecognized, unreported, because there's just no way to pick up on that stuff. We're able kind of in this model to give patients every opportunity to apply their education. So, I think most providers struggle with patients and talking about things like tapering. And by tapering, I don't mean tapering off, eliminating an opioid. I mean reducing a dosage. And like I mentioned, it's not this infinite escalator of increasing dosage to manage the pain. At some point, a patient has to pick a time to reset the body clock. And sometimes for patients, that's because they're going to have an operation, a hip replacement, a knee replacement, and they want better pain management following the procedure. Mm-hmm. So it makes sense in the months leading up to that procedure to lower your opioids in order to get the best surgical outcome and recovery that you can get. And so by asking a question with every patient, is there anybody who wants to talk about tapering today? You start to normalize behaviors, and you're normalizing it based on knowledge. Because a patient, when those things apply to them, will say, yes, I think we should discuss this. And then they can have one-on-one time to discuss that. But there's so many things that don't fit into 8 minutes that are incredibly important. We have a paper that's being published in the Journal of Opioid Management, and it looks at a high-risk protocol that is based on, there's any number of factors that could put patients into a high-risk group, but the high-risk patients get weekly prescriptions and have to meet with the prescriber weekly. And that's to force the conversation about what those risk factors are and what's being done to resolve the risk. And where we end up going with it is that if you're unable to resolve the risk, staying high risk is not an option. It's not healthy. It's not safe. And so for some patients, opioids aren't the right medication. And at least it lets the providers have that kind of discussion with the patients. And whatever the issue is with resolving risk, by having a weekly cycle, you have an opportunity to resolve it quickly. And that's what we found in the study. That moving to a 7-day prescribing protocol resolved the risk most quickly among the high-risk patients.
So in a nutshell, it allows the physicians to stratify their population, figure out who's the riskiest, spend the time in those areas. It gets the patients much more education. Not only gets them education, but it accelerates the education, helps the practice to become more productive. So it kind of hits all those different areas. How does that translate into, does it generally translate into more revenue for the practice? I mean, how does that, is there a way that all, it sounds like to me like it would be a pretty big accelerator for
yeah, so it supercharges the practices. One of the things that we learned in our early work for the National Science Foundation was that pain doctors, and in particular opioid prescribers, and the same thing true for primary care opioid prescribers, they felt that the patients needed a lot of time, but they weren't paid for the time. And so, since then, there have been new codes that have been created that make it a little bit more remunerative, but you'll never get out of that 8-minute model when you see patients one-on-one. And so from my decades as an operator in the pain space, I kind of rewrote the model relative to how the reimbursement works and how they structure, how the providers can structure their fees. And so it makes a substantial difference economically. And, I don't want to talk about specific numbers because there's a lot of variance by region.
Sure.
But, for a practice that has, let's say about 1,000 patients on long-term opioid therapy, kind of use rough numbers, it'll generate about $1 million in profit for them. So it's really substantial. And so it incentivizes them to take on these patients. And the reason that that's important to us is because ultimately we have a mission to help restore access for patients. When you think about it, the hassles with the insurance company and the pharmacy, for most practices, those go unpaid. That's friction in the system, and that adds to their cost. That's why, most of the practices are not excited about growing because it's turned into a low margin business. But, what our customers have experienced is we fix that. We create the right financial incentives, and that's validated first with the clinical outcome. So this isn't about money. This is about improving the clinical outcomes, but doing it in a model that really is advantageous to the practice to want to provide these services.
Well, it just seems like everybody wins. The patient wins. They get more access to care. They get the care that they need. The docs win because they could either spend their time, maybe go home a little early, get home for dinner more often, or see more patients, help more patients. The providers win. And then the reimbursement organizations win because it's lower cost. So right. Whoever it is, Medicare is spending less money, or the ACO. So it's one of the kind of those rare things where you've been able to align everything in such a way that everyone's winning. And
Exactly.
That's how you can kind of create that flywheel around that, and why you're seeing so much success from your solution.
Yeah, and it's interesting, Reese, because we've had this validated by the carriers where, what they'll notice is these extra visits coming through our customers, and they'll typically have an inquiry, why does the patient need all these visits? And when the outcomes are shared with them and just the overall cost reduction because they don't need the procedures, they're much more stable, they're not in the ER, then the carrier authorizes and approves all the visits because they know it's financially in their best interest.
Absolutely. Justin, one of the things that I've found in as you and I have been working together, and we've sort of seen kind of the perceptions in the marketplace. Opioid users, rightly or wrongly, they get stigmatized, almost like, they're using illegal street drugs. Sort of, whoa, you're an opioid user. I would imagine that in this world that you're creating with the practices and with the patients, that they're learning how to handle that and how to communicate and how to be comfortable with that. I was just kind of curious how you're seeing the perception of this, because it sounds like the reality is some patients are only going to be able to be treated with opioids. The reality was until your solution, access to care was very minimal. The situation was actually becoming unsustainably worse. So you've been able to kind of bring all of those things forward and move the ball forward. But I still feel like that perception piece, as they start to talk about themselves in that way, or as they start to understand themselves that way. Because the first thing you might think is, well, I'm an opioid user. And if everyone in the world's bouncing around you saying that's a bad thing, you may not feel that good about yourself. So I'm just kind of curious, are you starting to see kind of some impact on that side of it, kind of the psychological impact on the patient?
I think that's why the group is so important, the group approach, because what patients realize is it's not them being singled out. But you're absolutely right. We basically labeled anybody who uses opioids as they must be an addict, right? And that gets back to the idea of chronic pain. Why don't they just get over it? And, wouldn't that be nice? They would love to just get over it, but it just, it's fantasy land because it's a real condition, and we wouldn't wish it on our worst enemy. Right. I mean, that's how terrible life can be. Knowing that they're not alone, knowing that they have support. And I think the other part is that in the groups, they can share different strategies they've found to be successful in addition to the strategies that we teach them. So I think there's the validation that you're not a bad person, and this has nothing to do with you, and it's just endemic within the system. I think that changes people's perspectives. And I think that's super, super important because at the end of the day, there's the other side of the coin of this problem, which is interesting. And I think something we'll be talking about more over the next couple of years. We've done such a good job of convincing everybody that opioids are bad, that when people are being prescribed opioids after major procedures, they don't want to take them. They don't want to turn into an addict. And then the problem is they don't have a good recovery. They're not able to get back to physical therapy because they're in too much pain. So what happens is they have terrible outcomes. And so that's a problem that we're seeing more and more, especially among orthopedists, because, they're not set up to care for the patients on a long-term basis. And what we're starting to see are pain management specialists as part of orthopedic groups. So there's some avenue to move that patient to.
Interesting.
But, the simplest thing would be to do some education for patients before procedure and let them understand that they're not going to become an addict, and even do an addiction screen so there's evidence that they're not going to become an addict. But we don't do those things in this country. Very simple problems to solve. I think we still have work cut out, but it's just the other side of the coin. Nobody wants to be labeled as an addict, and nobody wants to turn into an addict. But it's nonsense.
That patient story has intrigued me as I've gotten to learn more about what OPOS is doing and the impact, because, at the end of the day, that's why everybody's in it, right? It's great if there's more, et cetera, but really what everybody's trying to do is improve patient lives and outcomes, and it's having a great impact. Now, back up a little bit, Justin, to, you've had a very great career as a technology developer and as a leader of businesses. Kind of step back, you said if it was 15, 20 years ago, what inspired you to get deeper into this pain side of it and become one of the world's experts around it? What was your inspiration around that?
I find the state of U.S. healthcare to be somewhat disappointing. As a country, we spend more money than anyone else in the world. But we're ranked, depending upon who's ranking, we rank 26th or worse relative to our outcomes. As a society, we tend to prioritize longevity over quality of life. And I think that's a terrible trade-off. And, I saw clarity around this issue, and I felt like we could solve it. I think we can redefine the standard of care around opioids to something that balances the risk with the outcome in a way that it could be implemented in primary care. We could leverage the experts. And it's clear that the model that we've used doesn't work as a whole. So we should be willing to try different things. And I think when we started OPOS, the outcomes that we've observed, those weren't part of the plan. Our plan was regulatory compliance and create data to support a more objective conversation between a patient and a provider, with the hope that that data would make them both safer. And it's just been incredible to see the results, the clinical outcomes that we've been observing. And then also to find that other clinical studies that have come along more recently have validated so much of what we see. And I think that it's really comforting to know that from a clinical study perspective, where you kind of create a somewhat artificial environment to study something, that principle actually applies and is embedded in a commercial solution that's available today. So the study and the findings of the study actually have a way of really becoming integrated in fabric. And since we didn't do the studies, it's not kind of a self-serving piece that I think you see so much in healthcare, where you have kind of pharmaceutical sponsored studies, right, that prove their outcomes. And one thing that I do want to mention, I think one of the big challenges also that we face is that in the United States, the amount of opioids that are produced every year are set by the DEA. It's not based on medical need. It's based on some arbitrary criteria that has nothing to do with patients. And what the DEA has done over the years is they keep reducing the amount of opioid that could be manufactured. And so what we're seeing is not just an access to care issue that we've been discussing, but we're seeing shortages at the pharmacies. And, it's also showing up as shortages in hospitals and medical centers, where they're having to delay and reschedule procedures because there aren't opioids for pain management. I think fundamentally, if we want to continue to prioritize longevity over quality of life, we're still going to have to deal with this issue. because you're just not going to get people to support the concept of longevity when they're absolutely suffering every single day. So we're going to have to come to terms with this issue. And where we're dealing with it now is taking all the time that the providers spend trying to either move prescriptions, because Schedule II prescriptions aren't portable. If it goes to a pharmacy and that pharmacy can't meet the supply, a new prescription has to be written to a new pharmacy. It's not transferring that. And in some states, if you have a prescription for 150 tablets and they only have 50, you don't get a balance fill. When they get more, you need a new prescription. And so when we talk about some of the things that drive patient anxiety, this is some of them, but I think importantly, it's driving real cost to the practices. So in our model, we have ways that they can recoup that as revenue, because at the end of the day, it's a combination of the pharmacies, the insurance companies, and the DEA that have created these hurdles. Ultimately, they'll pay for them, a huge inconvenience to the patients. But what I think is interesting is even if you add all these costs into it, it's still the most cost-effective long-term therapy.
I'm going to switch gears a little bit on you here just to talk a little bit more about the business side. With the relationship with Protega recently announced, how do you see that enhancing the offering and kind of how you're both working together? What does that do in terms of the impact on the solution and the impact on the market?
Yeah, so let me maybe give the viewers a little background on who Protega is and what they do. So Protega has a formulation of oxycodone, which is a short-acting opioid, and it's a safety formulation. So what that means is it can't be turned into a liquid to be injected. It can't be chopped up to be snorted. All of the kind of manipulations that can be done to opioids that addicts do can't be done to it. And so, interestingly enough, it has zero street value. So from a diversion perspective, like nobody wants to buy it. And the reason that that's all very important is that Protega is committed to supporting providers and patients through risk reduction and safety. And so that aligns very well with our mission. And through our partnership, we have distribution into all 50 states. What that's really helped us to do this year in 2025 is to expand from a much smaller number of states and have the solution available nationally. The other part of it is that the Protega as a company has relationships with the folks that treat chronic pain. They know who all the high prescribers are. And so that really gives us direct access to those folks and lets us help support them and their patients from a much broader based perspective. And I think what's also very interesting about it, and I think this speaks to some of the future, and I'll go off maybe on a little bit of a tangent and then come back to it. So when we look at clinical trials, right, and see that any medication is, 98% effective, we see just this incredible efficacy. One of the challenges is that once that medication or that therapeutic is released, the physician or the prescriber doesn't know what the inclusion criteria was for patients that were in that clinical trial. So when we see medications and we see them out in the market, we may see efficacy closer to like 10%, 15%. And the reason is that, and pain is a good example of this too, because, you got to kind of try everything to find something that works. So the prescriber is just trying different things to find something that works, which gives the low efficacy. So now to kind of come back to our discussion around things like short-acting safety formulation, because we do the risk stratification and because we have all the data on the patients, we can work with the providers to help better identify some potential treatment options for patients. And ultimately, it's their provider who's doing all the medical decision-making in conjunction with the conversation with the patient. But there are certain kind of use cases for, that particular opioid formulation, as well as, many other medical devices and other kinds of medications that don't always occur to the provider when the patient's there. And in 8 minutes, you may be aware of something, but may not have time to go into all the details.
Right.
And so what we try to do is use the data and the risk stratification to try to help the provider understand some different treatment opportunities that are available to patients. And ultimately, they'll make the decision. But I think, when we look at, let's say, high-risk populations, and a high-risk population, it doesn't necessarily mean that the patient's doing something wrong, right? We look at risk also in terms of morbidity and mortality. A good example is if you have somebody who's a caretaker, the caretaker is responsible for administering the medications to the patient. That's considered high risk, not because the patient may be high risk, but there's potential for diversion by that caretaker to take some of the medication. So their medication is Roxybond. So it fits perfectly in that scenario because with zero street value, somebody isn't going to steal it. The medication has the same efficacy as the generic oxycodone. So from the patient perspective, it's the same thing. Another use case is a parent that has teenagers in the house, right? That can also be another, really important risk factor. Anybody that just has a high number of tablets, another potential risk. So there are all of these use cases. And at the end of the day, it comes back to what I was talking about in terms of the basis of our partnership, which is overall risk reduction and improved safety. That's really, I think, a critical part of not just our relationship, but of what we should all be working to accomplish and achieve relative to the use of opioids for chronic pain.
A lot of audience, they're founders and heads of sales, and you've had a lot of great success over the last year, something like 7 to 8 times increase in your ARR. Can you just give a couple of highlights in terms of what you've done that's had that type of impact? What's been working for you? What did you try that's not working? Those kinds of things?
Yeah, I think about this all the time. The first thing is, and I think this is true of healthcare in general, and it doesn't really matter what your solution is, but if you're at the point of care, you need to understand that the relationship between the provider and the patient will be the same no matter what the organization is. So that interaction, it doesn't matter whether it's a community practice, it doesn't matter whether it's a large IPA, it doesn't matter whether it's, a large multi-state conglomerate with 2,000 hospitals. The patient and provider interaction is the same. And so it's really important to get that right, because you're not going to scale with any part of that being wrong. I think that's a really critical element. Also, another part, when you think about product market fit, it's too simple to think about how does my solution relate to the care provider and the patient. I have to understand, and we have to really be conscious of how it fits into the whole value chain. What about the pharmacy transaction? What about the payer? What about the medical device and pharmaceutical companies? What about the employer? Where do those all fit in? Because we can't advantage one over the other. Otherwise, it's not going to work. Mm-hmm. Right? They all have to have a benefit. And I think too often folks kind of glob onto an idea and they're so enamored with the idea that they don't realize that the deficit they're creating for a stakeholder is actually going to be the problem going forward, because providers have to operate across all these stakeholders all the time, and so do patients. Mm-hmm. So if you're not aligned, you're going to create friction somewhere, and that'll be your undoing. The other part is I think companies don't do enough to talk to all the stakeholders. And you should be talking to hundreds of people, across each of the segments. And when we started, my vision was to start with primary care, because, the profile generally for a chronic pain patient, they have multiple chronic conditions. And in an ideal world, you'd like to see those managed in primary care, because they're the best suited to kind of have treatment plans that may trade off some of the complexities across the different chronic diseases. And the thing that chronic disease has in common, irrespective of what it is, including chronic pain, is they have to be managed and they need frequent management. But when we got into primary care, what we found was that there was just an incredible knowledge gap, especially in rural communities. We found that a lot of patients were on just really high dosages of different kinds of medications that didn't work well together, things like opioids and benzodiazepines. And there was kind of a threshold where the patients weren't really appropriate for management at that point, primary care. But there was really nowhere to go. And so what really occurred to us was that if we could increase access among pain specialists to try to create a place for those patients to go, we would have a better long-term solution. And some of the challenge early on was that we felt that, in the kind of shift away from opioids, interventional pain practices had developed and they didn't want to write opioids. And the reason they didn't want to write them is, from a business perspective, that's a pretty low margin business. And they wanted to do procedures, which is high margin. In the shift away from opioids, the insurance companies were happy to pay for anything that wasn't an opioid. But the problem with that model is that the primary care docs who were referring the patients, it didn't do them any good to get the patients back a month later with a procedure that had short-term benefits, because all the primary care provider could do was write prescriptions. And that just wasn't a good scenario. And the primary care doctor didn't want that either. And so what we figured out was that working with the interventional practices, we could show them how they could create a very profitable business around the chronic care management side of chronic pain, and not only drive new revenue for them, but provide a better pool of patients to match with their procedures. And so when we get back to that idea of a multimodal treatment plan, there are certain points in a chronic patient's journey that a procedure is appropriate. And if you can get them the procedure at the right time, you can maintain the stability of that patient. By growing these larger catchments within the practice, it also helped drive more interventional business. Yeah, and so that was something that wasn't necessarily intuitive to us. But the reason that we figured it out is through talking with hundreds of people and recognizing that there were enough hybridized practices that, of practices that were interventional pain practices at their heart, but still had hundreds of long-term opioid therapy patients, that we could create a beachhead. And from that beachhead, we could prove the economics and we could prove the improved outcomes, and then be able to take that to other people and say, look, here's what we can do. And we're so confident in it that in our contracts, we actually guarantee the return on investment to our customer between 2-to-1 and 3-to-1. And what we say in our contract is, I'll adjust my pricing if we can't meet that ROI for you, because
that's big.
Because we know how it works and we've done it enough at scale. And by balancing the needs of the stakeholders, it's sustainable.
That's really powerful. So I know I've taken a lot of your time here. Let me ask you a last question here. And I know I'm going to put you a little bit on the spot here, because it's probably going to be a bit difficult, just given all the positive impact. If you think about, some point in the future and you 3 years, 5 years, 7 years, you look back, what would be the thing that you think you're going to be most proud of as you built the company and the impact that you had on the industry?
Number one thing that we would like to accomplish is redefining the standard of care and restoring access, and totally eroding that idea of long-term opioid therapy as opioid patients are addicts, and having people understand that it's a legitimate form of treatment and it's extremely powerful and it has its benefits, but it has to be managed appropriately. And I would like the lack of access of care to be a footnote in history.
Yeah, that's really powerful. That's powerful. Well, Justin, I just want to thank you. I always learn so much anytime we have interactions. I just want to thank you for taking the time to be with us and educate our audience on this really, really important area. And I'm just really excited to be part of it. And thank you for taking the time today.
Well, thanks for having me, Reese. I enjoyed our conversation very much.
Sparkscast Unleashed, a Sales Spark production, accelerating healthcare innovation.